Hi, my name is Neil Nathan. I hope by this point you've had a chance to look at part one of our presentation, and you're ready now to learn about how to treat mold toxicity. So let's get going. The three main components, to reiterate, of treating mold toxicity. Number one, super important, you have to be sure that your patient is living in a safe environment. That could be work, home, car, relatives they visit on a regular basis, but you can't get well if they're living in a moldy environment. Okay, that's one. Second, we're going to use the correct binders that bind the toxins that showed up on our urine mycotoxin test. And thirdly, if our patient is colonized, and actually most have, then we're going to need to go to antifungal treatment to get the mold out of the sinus and gut areas where it colonizes for a cure. So let's begin. The beauty of mycotoxin testing in the urine is that we know that specific mycotoxins appear to be bound better by specific binders. Okay, as an overview, ochratoxin is best bound by cholestyramine or Welchol, and to a lesser extent by activated charcoal. Gliotoxin is best bound by bentonite clay and N-acetylcysteine and the good probiotic yeast Saccharomyces boulardii. Trichothecenes and aflatoxins are best bound by bentonite clay, activated charcoal, and chlorella. Zearalenone is best bound by bentonite clay and Saccharomyces, as is aneatin B. We have no research that tells us what binds ketoglobicin, but what we found clinically is that by taking clay, charcoal, and chlorella, ketoglobicin disappears from the urine, and so we believe that it's fairly readily responds to the same treatment that we would use for the other toxic species. So let's talk about binding. The word binding is correct, but has an implication that confuses people. Many people are confused or baffled when I say when patients take binders, it can mobilize toxin faster than they can process it, because they're going, what are you talking about? Binding is binding. If something's bound, how does it get mobilized? So I want to spend a moment talking about that. It has to do with the word binding. The word binder, it's correct, but it conveys a sense that the material is bound, and I mean tightly bound, but it's not. For example, activated charcoal doesn't actually bind, but it adsorbs or adheres to the toxin on its surface. So on the very surface of the charcoal, it binds lightly. One of my patients described this as static cling, and that's probably closer to it. So another description, which I like, some physicians have taken exception to it, but if you had a pile of iron filings on a table and you had a big magnet and you grab onto the iron filings and you drag it along the table, think of the binder as the magnet, think of the filings as the toxin, and think of the table as the lining of the gastrointestinal tract. As you drag it along, some of the filings trickle off so that you start to bind it and pull it through the GI tract. But molecule after molecule after molecule, if you're using too much binder, you're really beginning the process of pulling it along, and what's left, these molecules, remember, they can be absorbed directly through the gastrointestinal tract and go back to the circulation. Patients actually begin to get more toxic if you don't use the right dose of binder. Now, this is a very elaborate long-winded way of saying you have to be really careful with binders, and I can't emphasize it enough. If you use too strong a dose, you will make your patient worse. This doesn't happen rarely. It happens a lot. So the art of treating mold toxicity is to be open to and keyed into tweaking the doses of the things you're going to give the patient so that they can handle them comfortably. Okay, having said that, so I first choose the binder that will affect the mycotoxin that is in greatest excess on the report, and then I work downward. So for example, if I have an ochratoxin level that is 3 times the upper limit of normal and a trichothecene level that is 10 times the upper limit of normal, I'm going to start with trichothecene. Okay, remember, dosing is critical. Now at this point, I'm going to bring in my experience with sensitive patients when I begin to give you doses. So at your first visit, if possible, carefully assess your patient's sensitivity or the strength of their constitution to decide on a preliminary starting dose. So you can ask questions like, when you take medication or supplements, do they ever bother you? If your patient says, no, I can take anything, never bothers me, then we're probably dealing with someone with a strong constitution. If you're dealing with someone who says, yeah, I tried a little bit of clay and it threw me under the bus, I got much worse. I tried 1 tablet of chlorella and I couldn't do it. Now you're probably dealing with a sensitive patient. That's critical to deciding dosage. Remember, there's no algorithm here. We're giving dosing based on our perception of what we think the patient can take comfortably. It's much better to undershoot it in the beginning than to overshoot. If you overshoot, you can make your patient sick for weeks, even months sometimes. If you undershoot, you're great. You can always add to it. So I have a very strong bias working with sensitive patients. Start low, work up. Okay. Timing of binders. So ideally, all binders should be taken away from food or other supplements, with exceptions. Now, for compliance and because of timing, I find that my patients do best if they take it once a day. If they can time it, certainly they can do it twice a day. So now, Saccharomyces, which is simply a probiotic, can be taken with food, and cholestyramine and Welchol should be taken with food, if possible, half an hour before you eat, with meal that contains fat to improve the ability to bind. So practically, for many of my patients, for things like charcoal, clay, and chlorella, I recommend taking them 2 hours away from food or supplements or medication on either side. So 3 in the afternoon or at bedtime works for most of my patients, timing-wise. Chlorella, clay, and charcoal are all negatively charged, so they don't bind each other. So you certainly can do that. But cholestyramine and Welchol are positively charged. So you don't want to be taking cholestyramine or Welchol with your clay, charcoal, and chlorella because you're going to get some binding effect, minimizing the benefits. Okay, so now I'm going to give you suggested doses for people who are sensitive, which is S, or constitutionally strong, which is CS. And these are just suggested, but it will hopefully give you a starting point of how to work. So, and we're going to take this toxin by toxin. For ochratoxin, for sensitive patients, you might start with 1/16 of a teaspoon and slowly work up to 1 teaspoon if tolerated. And I've had several patients get completely well taking 1/16 of a teaspoon of cholestyramine every 3 days. So many patients go, oh, come on, Neil, that's pathetic. What's that going to do? Sensitive patients often respond really well to tiny doses. So please don't let the patient get it in their head, oh, I've got to take more if I'm going to get anywhere here. Not so. Just find a dose they can comfortably take and keep them under doses that make them worse. Now, For a constitutionally strong patient, 1 to 2 teaspoons. People often take a scoop, which is 1 3/4 teaspoons, once a day. Again, either with food or a little bit before the meal, that's fine. If you're going to use cholestyramine, please get it from a compounding pharmacy because it does not contain sugar or Splenda. The commercially available stuff that patients can buy from a pharmacy contains sugar or Splenda, neither of which is good for them, especially the sugar, or I'll even say the Splenda, because sugar feeds candida and mold growing in their GI tract, and you don't want to do that. If the patient can't tolerate cholestyramine, which is the strongest of the binders, try Welchol, which comes as a 650 milligram tablet. Sensitive patients, 1/8 to 1/4 of a tablet once a day, working up to 1 or 2 tablets a day. For constitutionally strong patients, they can take 1 or 2 tablets up to 3 times a day with food. Okay. For charcoal, which is a weak binder for ochratoxin, I would start with 1/4 of a capsule or 1/4 of a teaspoon once a day, and then slowly work up to anywhere between 2 and 3 capsules once a day for stronger patients. Again, this is simply how to take cholestyramine in more detail. For gliotoxin, if we're going to take Saccharomyces for a sensitive patient, we might use a sprinkle or 1/4 of a capsule on food using a lower strength Saccharomyces. Saccharomyces comes as 3, 5, and 10 billion units per capsule. And so use the lower dose for a sensitive patient, a higher dose for a constitutionally strong patient. And ultimately, you want to have them take 1 capsule with each meal. For bentonite clay, with a sensitive patient, I like to use liquid bentonite clay, starting with 1/4 to even 1/8 of a teaspoon once a day. For patients with stronger constitution, 1 to 3 capsules of metaclay, which contains approximately 500 milligrams of clay, is great. For NAC and acetylcysteine, 500 milligrams once a day for sensitive patients. Patients who are sensitive to glutathione may not be able to take this because the body converts NAC in the cell into glutathione. Be careful with it. For patients who are stronger, 1 gram, 1,000 milligrams twice daily is a dose for them. For trichothecenes and aflatoxins, bentonite, clay, charcoal, and then we can add glass-blown chlorella, 200 to 300 milligram tablets. For sensitive patients, we'd start with 1/4 of a tablet once a day. For patients who are stronger, you can take 1 to 3 tablets daily or twice a day. Again, it's important enough that I'm going to remind you, binders can and do mobilize toxins faster than a compromised detoxificational system can process it. Now, this will make our patient worse. Again, go slow. A lot of patients are concerned that binders may cause constipation, particularly the prescription materials like Welchol and cholestyramine. So constipation is common. Usually you can manage it in the vast majority of patients by simply titrating their dose of magnesium and buffered powdered vitamin C, taken several times a day. And usually that will work well and have other therapeutic benefits. What about diet? The basic diet for mold toxicity is a high protein, low carb diet. The importance here is low carb. Carbs feed mold and candida in the gut, causing them to grow, and that is counterproductive. So as a ballpark, I'm tossing out 20 to 60 grams of carbs a day is ideal. Some of my patients find they just don't feel well when it's that low. You may have to go to 80 to 100 grams a day. So paleo or keto are my currently preferred diets. And that's the basic. One of the questions that comes up is many people have read books saying that you want to avoid yeast-containing foods like cheese, vinegar, and mushrooms, kombucha, Does that matter? It's my opinion that they don't. I believe that the proscription on avoiding yeast products came from the original writings of Dr. William Crook, who got us all into Candida many, many years ago, when he was under the belief that all yeast had to be avoided because Candida was involved. Yeast per se does not contain Candida, and that's what we're concerned about. So I have not found avoiding supposedly yeast high materials to be necessary at all. And so in my world, that doesn't matter. Another question that comes up, and a lot is talked about this, is there a significant amount of mold or toxin in food? Some authorities say there is, and I would say that there isn't. The vast majority of exposure to mold comes from water-damaged buildings and water-damaged structures, period. That's the major source of toxicity. Is there toxins in food? Yes, but to a minuscule amount. I believe that a lot of people make a lot more about what's there. Although the FDA does not limit the amount of toxin in food as much as they should, as I showed before, and the least a little, and I'm going to show you right now, I'm not convinced that the toxicity potential in food is issue. Yes, you will note that there are studies in the medical literature which show outbreaks of mold toxicity when food has been stored poorly, or it's in peanuts that made into peanut butter, or in grains stored in silos. There are outbreaks, but I don't believe the vast majority of people who have mold toxicity that it comes from food. There is some in dried fruit, aged cheese, mushrooms, coffee, beer, wine, processed meat, tomato, fermented food products. That's true. Okay. I did a study. It was a small one. We didn't have much funding for it, with Great Plains, on 8 patients to study this. To my knowledge, there's no other study been done. All 8 patients avoided all potentially moldy foods for 10 days. And at that point, they had a urine mycotoxin test done. Then they pigged out on those supposedly moldy foods for 10 days. And then we repeated the urine mycotoxin test. Of the first 8 patients, to our surprise, 7 patients' mycotoxin levels went down across the board by eating supposedly moldy food. 1 patient had a slight rise in ochratoxin and no other toxin. So I think that more is made of toxicity in food. Some people go on low mold diets. I'm not sure that that is necessary for the majority of patients. What we're asking them to do is already so borderline overwhelming that I try to avoid making life any harder for them than it already is. Okay, so once the binders are up and running, if the patient has markedly improved in a short period of time, which is not typical, but you will see it, you can continue treating with binders alone, and some people will get well just doing that. Not everyone colonizes. Now, in my experience, and remember that I'm getting referrals from physicians with the more complicated patients, and from my patients, almost everyone has colonized. So remeasuring urine mycotoxins 3 or 4 months after the binders are fully on board will help to assess progress. If the patient is not making much progress and the numbers are going up and there's no sign that this is working adequately, then it is very likely that they have colonized, and you can now consider beginning the antifungal treatment program for the sinus and gut areas. I usually start with the system with the most symptoms. So if someone has fairly severe nasal congestion and a chronic nasal drip, chronic sinus infections, I start with the sinus. If someone's primary symptoms are GI-based, I'll often start with the gut. Now, there are some tests you can do that will help decide whether people have colonized. For example, Great Plains has an oat test, and if someone has an arabinose that is elevated on an oat test, that is strong indication that they have candida. Now, on our urine mycotoxin test, if the gliotoxin is elevated, that's a strong indication that they probably have candida as well. Also, on the oat test, several other fungal components will indicate colonization, but it's a weak test, and I would not base treatment on that test alone. Okay, so I will usually begin treatment gently with a colloidal silver in the form of Argent 23 as a nasal spray, followed by a sinus antifungal and biofilm dissolving agent. The specific antifungal should be tailored to the sensitivity and reactivity to the patient, just like the binders were. So constitutionally strong patients can usually start with an amphotericin B nasal spray, starting at 1 spray, using often a sprayer or an atomizer once a day, then working up to twice a day. Sensitive patients should probably start on something gentler, like nasal nystatin spray. For patients intermediate in reactivity, I'll use either an itraconazole 1% nasal spray or a 2% ketoconazole nasal spray. Now, that will take care of the antifungal. Colloidal silver and an antifungal are synergistic. Each makes the other work better, so I often use them at the same time. So if you're using a nasal spray, literally squirt, squirt with the silver, squirt, squirt with the itraconazole, ketoconazole, and then have the patient tilt their head back for a few minutes, let it get into their sinuses, and we're done. Now you then want to add a spray that has biofilm dissolving agents, because mold and candida and some bacterial species make a great deal of biofilm, which can prevent the antifungals and the immune system from getting at the mold and candida. So we typically will add EDTA into an atomizer or nasal spray. Originally, we used what's called BEG spray, which is bacitracin, EDTA, and gentamicin. In the last few years, I've taken the G out. I only use BE spray because I have found that the gentamicin predisposes to bacterial resistance, not fungal resistance, and has had some systemic effects in a few patients. So we wanted a biofilm dissolving agent, we want an antifungal, and colloidal silver. Then I turned my attention to the gut, or I might have started with the gut if that's the main symptoms. Again, I like colloidal silver, starting at 1/2 to 1 teaspoon a day. Typically, if I think the patient has candida as found by gliotoxin or an oat test, I will typically start with nystatin, prescription, 500,000 units, once a day, slowly working up to 2 twice a day. I will then add Sporanox, 100 milligrams. Now, nystatin, to backtrack just a second, is pretty well tolerated even by sensitive patients, but go slow. With Sporanox, I recommend starting 1/2 or 1 of the 100 milligrams every 2 weeks. For strong patients, constitutionally, I might start with 1 a day and then work up to as much as 1 or 2 twice a day. For some sensitive patients, Michael Gray taught me that you can have compounding pharmacies make up a solution of 0.6% amphotericin B, which is well tolerated. You can use it as a nasal spray, and then you can use it orally, starting in doses from 1 to 2 cc's daily to 10 cc's twice a day. For biofilm in the gut, I typically would use a biofilm dissolving agent like MCBFM, 1 to 2 capsules a day, or Interphase Plus, 1 to 2 capsules a day. And here's several papers which I encourage you to look at. These are Dr. Brewer's papers, which put this whole treatment program on the map pretty much. I'm happy to say that I've worked closely with Dr. Brewer, who is a good friend, and his information has been invaluable throughout the years. And so this slide and the next slide, I had mentioned in the first lecture that Dr. Brewer had shown that 92% of patients with chronic fatigue had measurable mold toxicity, and here's the good part, responded amazingly to the treatment for mold toxicity, which we've just outlined. He then published 2 other studies, which are all listed here, of 100 consecutive patients. The first treated with amphotericin B as a nasal spray, the second treated with nystatin as a nasal spray, both of which showed 94% cure rate on the amphotericin B and 89% with nystatin. Okay, other treatments for mold. We know that certain probiotics can have a specific effect. For example, Lactobacillus rhamnosus and casei protect against aflatoxin, and they increase catalase and glutathione peroxidase to improve the body's ability to make glutathione. Lactobacillus plantarum can also help remove aflatoxin, as can I can't even pronounce it, Beribacillus laterosporus. And here are a couple of papers documenting that. One of the questions that some people have argued about using antifungal treatment is that they're afraid of antifungal drug resistance. So this is a fairly recent paper, 2015, and quoting this, and this is from the HHS. Resistance to antifungal agents remains relatively uncommon, as the majority of fungi retain susceptibility to the commonly used fungal agents. So in my experience and that of Dr. Brewer's, we've compared notes on it, we rarely see antifungal resistance, which some people have stated is going to be a problem. Having treated 3,000 or 4,000 people with mold toxicity successfully, I just don't see it. What about allergy? I said in our first lecture that some patients are both mold toxic and allergic. Now that's really a problem if you're colonized with mold. That means you have in your body something you're allergic to growing. So the treatment program will help both toxicity and allergy, but some patients benefit from allergy treatments as well. I would recommend the American Academy of Environmental Medicine, which teaches excellent courses on how to approach the allergy component, or you can think about referral to an allergist or people trained by the AAEM. The role of glutathione in treatment. Here's a paper by Jeanette Hope, in which she notes that toxins can decrease the formations of glutathione. We know that they do because toxins trigger the cell danger response, in which the body protectively shuts down the methylation cycle, hence stops making glutathione to the same extent. So you can use glutathione in treatment in many forms, intranasal, oral, or intravenously. But, and here I want to be the devil's advocate, it may worsen sensitive patients. Glutathione has the ability to mobilize mold toxin faster than some patients can process it. So if a patient can handle glutathione, great. If they can't, don't use it, because it'll make some patients very sick. There's one other component to glutathione that I want to bring to your attention. Glutathione is the end product of methylation. And as such, if you take glutathione, there's a feedback loop with the body so that the body goes, oh, you got all the glutathione you need. I'll stop making glutathione. Hence, it'll shut down the methylation cycle. That may not be of benefit in the long run. So be careful with glutathione. Is it helpful? Potentially, yes, but it's not the be-all, end-all. So in this regard, I'm going to be the Lorax. I speak for the trees. So here I'm going to speak for those who become so sensitive that no one believes them. So I am the voice here of glutathione caution. Even though we talked about using glutathione for provocation, if I have a sensitive patient, I'll either have them take it in minuscule dose for only 1 day before they collect their urine, or I won't have them take it at all, because the setbacks from using glutathione can be profound. Other useful treatments, other adjunctive treatments. I'm going to list here a number of products that I have found helpful, remembering that I have no financial ties to any of these companies that make these. Okay, from Beyond Balance, they make ProMyco, which supports the ability to detoxify, Mycorrhigan, which assists with antifungal treatment, and Toxis Bind, which helps to bind some of these toxins. Other products, Byron White makes A-Fung, which is very strong. I would only use that in constitutionally strong patients at low doses. The biotoxin binder from Cellcall is primarily humic and fulvic acid. Now keep in mind that although those are binders, I find them weak, and I don't find those products particularly helpful. Some of my colleagues disagree and do find them very helpful. Again, Biocidin nasal spray can be very helpful. And I want to point out that although I am providing you the allopathic treatment, because that's what I am, I'm also very fond of the naturopathic treatment, which is reviewed beautifully in Jill Krista's book, Break the Mold. So those of you who are interested in that approach, I would encourage you to look at Jill Krista's book. Other useful treatments, intravenous phosphatidylcholine. I love intravenous phosphatidylcholine. Yes, you can use oral phosphatidylcholine, which does have a role, but the effect of the oral is a drop in the bucket compared to the intravenous. With sensitive patients, start with very tiny doses, 0.5 to 1 cc once a week, and slowly bump that up. With constitutionally strong patients, I'll start with 1 vial, which is 5 cc's or 250 milligrams, and slowly increase to 2 to 3 vials, often once a week. Another treatment that I have found helpful in shortening the course of treatment is ozone sinus insufflation, which I'll show you some photographs in a minute. Start very gently with 2 to 3 cc's of ozone in each nostril once a week at low dose, 11 gamma, and slowly increase to 10 cc's in each nostril once a week. Ear insufflation may also be helpful. Okay, what you have here is simply a syringe, ostensibly filled with ozone, and it's a butterfly, and I've cut the tip of the butterfly needle off. I'm going to place the tip in my nose, take a deep breath in, hold my breath, squirt the ozone into my nose, then I'm going to pinch my nose for about 20 seconds, and then exhale through my nose. Try to breathe, not through your lungs. We don't want any ozone getting into your lungs. And you can do that on both sides. That's nasal insufflation. A modified stethoscope is used to provide ozone. You simply put that in your ears and run ozone at low gamma, 11 gamma, for a couple of minutes. Okay. Other approaches which we found helpful, low-dose immunotherapy, or LDI, developed by Dr. Ty Vincent, using the patient's own nasal watchings, which I alluded to in the first lecture. I also want to make you aware of Dr. Bill Ray, who unfortunately left us recently, used to make a nasal washing autogenous vaccine, which worked very well. And we believe that it was doing something similar to what Dr. Vincent is doing with nasal washings. Dr. Vincent also has an antigen called yeast, which is specifically helpful for candida in the gut and sinuses, starting low doses and working up to it. Transfer factors have recently been developed. The one called transfer factor Enviro includes the stimulational ability to improve the body's immune response to penicillium, fusarium, aspergillus, cladosporium, and candida. We've just been talking about mold toxicity, and we've been talking about sensitive patients, but I'm going to expand that for a few minutes now. If you have, as I do, very sensitive patients, so patients who are very toxic, many are so sensitive that they cannot start binders without intense reactions. So consider starting these first. Number one, work on assisting toxicity, which I'm going to cover in more detail shortly. Help with lymphatic drainage. Help with modalities for the kidney and skin. The intravenous phosphatidylcholine is really helpful for some of these patients. So these can be very helpful. For really sensitive patients, I want to come back to a big topic, which we didn't have time for today, which is mold toxicity triggers in many, many, many patients mast cell activation, limbic dysfunction, and vagal nerve dysfunction, which is essentially autonomic dysfunction. So many of our sensitive patients have extreme reactions to eating. They have a lot of difficulty with food. That's not necessarily food allergy, which is often mistaken for. It's likely to be mast cell activation, which is treatable. In addition, limbic dysfunction. The limbic system is the part of the brain that monitors the body for safety and controls emotion and sensitivity. So many of our mold patients have difficulty with anxiety and OCD and mood swings. That's limbic. So is the sensitivities that we've talked about. Sensitivity to light, sound, touch, chemicals, EMF. So if your patient has that, they may be so sensitive that you have to first treat the limbic system, the vagal system, and mast cell activation, or you're not going to be able to even give them tiny doses of binders. Super important, but that is a whole lecture or two or three on its own. We don't have time for that today, but it's really important you understand that. If your patient is struggling and having difficulty, think limbic, vagal, mast cell activation. And I have at the bottom Annie Hopper's DNRS program, as well as Ashok Gupta's amygdala retraining program, are the two that I use the most for limbic rebooting, and it's often essential as part of the treatment program. To re-emphasize that, for really sensitive patients, consider limbic retraining, polyvagal nerve strategies first. If they react within minutes of eating or drinking with symptoms of histamine release, meaning abdominal pain, cramping, diarrhea, sweating, hives, itching, chest pain, nasal congestion. If that occurs quickly after eating, that's not food allergy, that's mast cell activation. And again, although we didn't have time to talk about it today, I can't not talk about the effect that mold toxin has on the pituitary. It profoundly affects the ability to regulate thyroid, adrenal, sex hormones, and ADH. So early on, you want to test all of those hormonal areas, but realize you're trying to hit a moving target. You cannot completely get those into balance while the patient is mold toxic, but be sure you look for it, because many patients have some of their symptoms, fatigue, sweating, cognitive issues, maybe thyroid or adrenal or sex hormones may also play a role. And some of that can improve quickly if you treat that early on, at least to some extent. So very important. So let's give you a case history, which will pull some of this together. I had a 20-year-old woman referred to me by the Cleveland Clinic with a history of severe recurrent syncopal episodes. Now, these were 10 to 20 a day, with extreme fatigue, frequent joint pains, cognitive dysfunction, paresthesia. She said, my whole body gets paralyzed, dizziness, and anxiety. Symptoms were markedly exacerbated by exposure to heat, hence temperature dysregulation. Johns Hopkins had diagnosed her with having POTS. Complete repeated neurological examinations in a university setting were negative. Now, her symptoms had actually begun 5 years earlier, slowly and insidiously worsened. She did have a history of a tick bite and mold exposure. Her IGeneX Western blot was +4 for the 31 with a positive epitope and a +8393, meaning likely Lyme. Although she did have a test that is not available currently called the Advanced Lab Lyme test, which was negative and probably the most accurate available. So she came out to see me in my office in California, and I must confess that her syncopal episodes were impressive. I would be sitting across from her. I'd like to think that my reflexes used to be really pretty good. Her mother was sitting right next to her, and she'd be talking to me, and all of a sudden, with no warning, she would literally keel over in her chair. And she did this multiple times in the 2 hours we spent together during my initial intake with her. Fortunately, her mother had faster reflexes than I did because she caught her every time. Very impressive. Okay, so in September of 2015, a real-time mycotoxin test showed a trichothecene of 0.30, and that's her test. Keep in mind, this was before we had gliotoxin and zearalenone available on the real-time test, but it showed a moderate elevation of trichothecene. At that time, maybe 1.5 times the upper limit of normal. So keep in mind this phenomena of compromised detoxification, because she was really sick. That couldn't be the amount of toxin in her body. So this helps us to understand this tip of the iceberg effect that I talked about in my last lecture. Okay, she was really sensitive. We started because it was trichothecene, and the things that worked are chlorella, clay, and charcoal. She was really sensitive to everything, but we started with a quarter of a tablet of chlorella, and it took 3 months to working up to taking 1 chlorella a day. Her glutathione level, by the way, was very low at 2.9. From the lab that I use, 3.9 is normal, meaning her methylation was severely compromised. Okay, so by January, she had worked up to 2 chlorella a day, but keep in mind that even on this tiny, tiny dose of chlorella alone, her syncopal episodes were down to 1 or 2 per day, way down for the 10 to 20 she had. We slowly added intranasal, nystatin, Argentin 23, Beg spray. By March 1st, her syncopal episodes were down to 1 or 2 per week. Energy and cognition were markedly improved, enough that she was successfully able to resume online college courses. Now, in March, we repeated her mycotoxin, and it showed an ochratoxin level of 1.91, negative on the first test, aflatoxin of 0.72, borderline. Trichothecene had gone from 0.3 to 0.65, and gliotoxin, which hadn't been measurable because the lab hadn't done it yet, hadn't put it onto the menu yet, was a whopping 7.76, which is 30 times the upper limit of normal at that time. So massive amount of toxin in her level, which we suspected. So keep in mind, her low initial test by no means ruled it out. So by March, although she was still having some electrical shocks and tremors, much less, rare syncopal episodes, which were more related to stress, she was able to take on a part-time job as a sales assistant, as well as completing her online college courses. And this is the follow-up showing that those numbers which I put on the slide previously. I continue to follow her. As of Christmas of 2019, she graduated from college and began graduate school. She's had some flares up, when exposed to mold, but nothing like her initial presentation, and basically she's living a normal life. In the time we have remaining, I'd like to talk about detoxification and also bring up a fairly new, huge piece of information that I've worked on with some of my colleagues. So, most of our patients, as we've noted, have seriously compromised abilities to detoxify. Now, some of this relates to individual genetics. We can measure SNPs, which can be helpful in this regard, but it also deals with gallbladder and liver function, gut, kidney, lymphatic function. In this regard, one of the things I like a lot is a wonderful book by Dr. Joseph Pizzorno, who is a well-recognized expert on environmental toxicity, wrote a great book called The Toxin Solution, which provides practical nutritional and supplement approach over 2-week intervals. And he has 4 different diets. One is a general detox diet, another one is specifically for the gut, another one for the liver, and another for the kidney. What I like about them is that they are doable. You can do them over 2-week intervals and then take a break. So the patient can do it for 2 weeks, wait a month, repeat that if their body likes it, or go on to the next one. And so over a period of 6 months, you can do all of these, and my patients have often found it very helpful. Okay. Now, some of this is super basic, and I'm not going to dwell on it, but you typically want to have your patient avoid toxins in food, water, and their environment. Basically, eat organic. You want clean water and clean air. That means, of course, getting their home remediated or at least certainly checked out. You need to be sure to have normalized bowel function. Constipation must be avoided because if stool stays in the gut for a prolonged period of time with bound toxin to the binders that we're using, those binders are going to drop off, as we talked about, get reabsorbed. That won't work. So you've got to keep their bowels moving. Sweating is a fabulous way to get rid of toxins, not just mold, but many environmental toxins respond to sweating. So here, I want to emphasize that this is all about the toxic load. I've been talking exclusively about mold, but I don't for a moment think that that's the only thing I'm treating here. The binders that we're using and the treatments that we're talking about will help the body detoxify from other things. And as you lower the toxic load, then everything good happens. So I'm going to give you specifics now, basics. So with gallbladder function, gallbladder being critical here because it's what's squeezing bile bound to toxin that the liver is processing here. First, we want to improve the ability to make bile. And for that, we can use acetyl L-carnitine, calcium pyruvate, panathine, phosphatidylcholine, and ox bile. To mobilize bile, we can use bitters. Quicksilver makes a particularly good one. Globe artichoke, milk thistle, and coffee enemas. And in this regard, ozone enemas can also be helpful as well. For the gut, you can run any number of tests to pinpoint gut imbalances, a CDSA 2.0, a GI map, whatever your favorite way of doing it is. So we want to provide probiotics to repopulate the gut. We want to kill the pathogens. I'm going to emphasize that in a moment. Find food allergies and eliminate them. Add fiber. Now let's talk about L-glutamine. People use L-glutamine to treat leaky gut. However, a lot of my patients will convert L-glutamine to glutamate, which is neuroexcitatory and will often make their psychological symptoms much worse. Be careful with L-glutamine. Okay. The basic teaching of functional medicine is whatever's going on, treat the gut first. Got to get the gut working. That is true. But you will not be able to use the techniques and methods that you've learned to treat the gut until you get the mold and candida out first. So I've had way too many people referred to me who saw physicians for 2 to 3 years trying to get the gut fixed and couldn't because they have to get the mold and candida out first. You got to know your priorities. You all know basically liver detoxification, phase 1 and phase 2. Okay, so for liver detoxification, the most gentle one that I know of, which is really good in my sensitive patients, is Toxese GL. You can start with 1 or 2 drops, work up to 5 to 10 drops twice a day. Milk thistle, alpha lipoic acid, NAC, artichoke extract, indole 3-carbinol are great. And there's a homeopathic called Epohepat, which you can slowly work up to 5 to 10 drops twice a day, which I like as well. Adjuncts to detoxification. Frequency-specific microcurrent is a great device. You can specify the toxin and the organs of elimination. Lymphatic massage, very helpful. Most of our patients have clogged up lymph and really need to get it mobilized. Oil pulling is a very gentle way to go about it. And as I just mentioned, rectal ozone can help with that as well. So last year, with a team consisting of myself, Beth O'Hara, Emily Givler, Larry Young, and Deanna Minnick, we just completed a literature search, a deep dive, if you will. What we were looking for is to learn what we knew about how each mycotoxin is specifically detoxified. So here it is. Okay, so I apologize for the slide, but I would urge you to take a screenshot of this and use it if you're going to be treating mold. On the left, we have the detoxification pathway. Next to that, the specific mycotoxin that is processed by that pathway. Next to that, foods that are known to improve the functioning of that pathway. And next to that, dietary supplements that improve that. A plus or a minus means, plus means upregulates, minus means downregulates. So let me show you how to use this table. So if your patient had ochratoxin, one of the commonest ones that we find, the mechanisms that we have learned through the medical literature that work are glucuronidation, glutathione conjugation, amino acid conjugation, and microbial hydrolysis. So looking at the table, how do we do that? To improve glucuronidation, we can use supplements including quercetin, curcumin, resveratrol, CBD, ellagic acid, and astaxanthin. Nutritionally, cruciferous vegetables, turmeric, curry, citrus, grapes, berries, walnuts, pomegranate, black currants, and salmon. You got to take some of those foods with a little grain of salt because the fruit part you might want to keep down so that we're keeping the fructose level from stimulating the growth of candida and mold. If glutathione conjugation needs assisting, we can use genistein or GSH assist. And again, some of the same foods, including fermented soy, will work here. For amino acid conjugation, this is a little different. We can supplement with glycine, taurine, glutamine, ornithine, arginine. Again, be careful of glutamine. Foods, turkey, pork, chicken, pumpkin seeds. Okay, so this presentation had mold as its focus. One of the things I want to at least mention is, given the presentation of a complex patient with mold and Lyme, viral infections, parasites, heavy metal toxicity, methylation dysfunction, mast cell activation, mitochondrial dysfunction, the difficulty that most physicians have, in my experience, where do I start? What do I have to do first? So start with the pathology that explains the vast majority of your patient's symptoms. Usually this will be mold toxicity or Lyme or both. If it's both, my bias is to start with mold. It is less invasive, less difficult, less hard on the body. Because the symptoms of mold toxicity overlay Lyme so thoroughly, you'll often find that what looked like Lyme disappears when you treat the mold. Regardless of which illness is primary, First, figure out how sensitive your patient is, because you may need to address the limbic, vagal, or mast cell system before you even start to work on the mold. Complex illness is not like simple models of deficiency we saw in the past. Just merely identifying a deficiency and treating it will rarely be effective. Okay? You need to figure out where the patient is in the healing cycle to interface with it correctly. For example, even if you determine that your patient has a methylation issue and mitochondrial dysfunction and viral reactivation, which most of our patients do, attempting to treat these before treating the primary cause of inflammation, which is usually mold or Lyme, is usually unlikely to be effective. Start with the cause. Please do not cut corners or use shortcuts. I've had lots of referrals from patients who used a binder or two. Use every binder you need for each of the mycotoxins that you've got. You have to bind all of the toxins present and treat the fungal candida reservoirs for long enough to get negative urine testing results, and then add 3 months. So here's the biggie. This takes time. Rarely will people get completely well in less than a year. So let them know from the beginning, we're in for a long haul, but it's treatable. My mantra, if some is good, more is not better. Commonest rookie mistakes. The physicians that I've seen who jump in with antifungals before the binders are fully on board will often get into trouble. If you kill mold and release the toxins in the mold cell before the binders are on board, you're likely to make your patients worse. Second, many people start with too high doses of binders. They'll start with 3 charcoal and 3 clay right from the get-go. That's a great way to throw your patient under the bus. Starting binders before the patient is ready. Again, you may need to treat mast cell activation, limbic and vagal dysfunction first. We're still learning. This is basic. The good news is we know way more about this than we did 15 years ago. We really can help the majority of our patients already. However, if you learn of new treatments and approaches, please share them with me. Please feel free to email me so we can disseminate the information as soon as possible. Thank you. You are our future. You have the courage to remind a broken medical system about what is true and important, even when it's lost its way and hates to be reminded about that. Your personal growth allows the development of the compassion and discernment necessary for the journey. If you're listening to this lecture, you are already part of the future. You're already aware that you need to learn this information to help patients, of which there are millions that need your help. For more on this, I encourage you to look at my book, Toxic, which goes over all of this information in even more detail. If you want to give your patients a book or their family that is easy to read because it's only 40 pages, a summary of mold treatment is in my current Mold and Mycotoxin Current Evaluation and Treatment book, 2022. And for something a little bit off target, my new book, Energetic Diagnosis, might be of interest. Thank you very much for your attention, and I hope this will be helpful in getting you going on treating mold. If you're already doing it, I hope there are some pearls in here that will help to do it better. Thank you very much.